Wait, we are not live yet? Good afternoon, everybody, and we are back on day 2 at the CRISP TV, and the conference has been going great. With me, I am your host, Dr. Abad Khan. I am practicing as interventional cardiologist at St. Joseph Hospital, Ghaziabad. With me right now for the CRISP talk, we have Dr. Ajit Mulasari, sir. Really a stalwart and does not need no introduction, really. He's a director of cardiology at Madras Medical Mission, Chennai, and has more than 200 publications to his name. An expert operator, and more importantly, what is needed right now currently for our generation, an absolute expert teacher. Sir, good afternoon and welcome, sir.
Good afternoon.
Sir, is there a difference you have observed between rapid expansion of skills among the new age generation interventional cardiologists as progression of new tools and technology, but not so rapid, rather a significant slower pace of genuine data and high class data is being published in India in spite of a large volume of teaching programs currently going on?
Well, I think it's a more basic problem. But what's happening is that we have, right from our MBBS days, no clear training in research. We never had a course in statistics at MBBS. So basically, right from day one, which is nothing wrong there, you're trained in your clinical skills. So right from your MBBS days, you're asked to see patients, make diagnoses, do investigations, and as you progress to your MD and DM, the whole trend continues. Unfortunately, you can't suddenly become a researcher once you finish your post-graduation or you're a teacher or whatever, because you don't have the skill set to do research. And this is an endemic problem in India and many developing worlds, that large amount of good work is done, large amount of clinical skills are there, interventional skills are there, not only of the younger generation, of the older generation, but hardly any publications of huge importance in big journals. And this is a concern for me as a teacher.
Perfectly put, sir. A concern for the teachers, concern for the society as a whole, and for the specialties particularly. Sir, also in many countries like Europe, also Brazil, Argentina, and a lot of emphasis has been given to the registry data, not only the randomized trials, but the registry data, which actually reflects the ground level of work being done in the local environment. Why are we not able to secure this huge potential data and potentially tap it down and publish it?
So, as you said, there are two ways of doing research. One is registries. Why do you need registries? Because they are a large volume, so small events, like for say stent thrombosis. It happens only 0.3, 0.4% of patients. So if you have just 1,000 patients, you're not going to see a big event rate. But if you have 20,000 patients, you're going to see that event. So you need large registries to pick up the small events, number one. Randomized studies are good, but it excludes a lot of patients. If you look at randomized trials, say in a left main patient, you may not have the classic all-inclusive left mains. So you don't know whether this data is applicable to the whole subset of patients. Why are we not doing registries? I'm really not sure why we shouldn't, but I've been part of some of the registries of stents right from the day one. We had the Science India registry, we had the Tuxedo trial, which was published in New England Journal of Medicine. We had the Promise Element registry, which was published in Asia Interventions, the Science India. These are all 1,000, 2,000 patients study registries, which were published in reasonable journals. So I think it's time we did both. We did the registries and we did the randomized trials. The randomized trials is to look at a specific research question in a particular group of patients. And a registry is in that group of patients and all-inclusive data so that small events can be picked up.
So perfectly put, that for picking up the small events which are small by data for us may not be small for the patients. So registries are supremely important, and just along those lines of he being a teacher first and then an interventionalist also, I remember presenting a case not so long ago in a conference where sir was moderating the session. I was presenting a complete revascularization where I did a right coronary artery angioplasty and simultaneously opened a LAD CTO in the same setting, retrograde CTO, and he just nodded his head in disbelief that what I was doing, but at least appreciated me for doing a retrograde CTO in a STEMI situation at least. Also, he told me at the end, and I will never forget that that it is great that you have done that, but do not do it again. And I have never done that the same thing. So that's the power of a great teacher, sir, that people listen to you. So the question is, what do I have to do for the next 25 years to become like you?
Well, I don't think I'm a sort of a person who you need to compare yourself with. You are yourself, and I think that as a clinician, you see a lot of patients, and you see much more patients than in any other part of the developed world. So the clinical material that you're seeing is so huge that you can make a lot of research questions based on Indian data. And this needs to have a construct, and that what I call is a research proposal. Before you start writing a paper, you should have a research proposal. And that's very clear in my mind. Yes, you can write a case report here, a case report there, and publish something, but that's not a great research. The question has to be clear first in your mind. What are you doing this for? You have to define its aim. And the aim has two important things. What's your objectives? What's your primary objective and what's your secondary objective? For example, I'll give you an example. I'm doing a stent trial and I want to know this stent versus another stent. What are the outcomes? Now, the study has to be very clear. Your aim is to study X stent versus a Y stent. Number two is the outcome is say MACE, and the primary objective is say death, MI, revascularization. The second objective may be something else like quality of life or stent thrombosis, or some smaller events can be secondary objectives. Finally, you need to budget that study correctly, because otherwise what will happen is you will start a registry and you have no money to complete the registry, and after 1 year you say, oh, I don't have the money to run the registry. So you need to budget it. Everybody, the CRA, the clinical people, the cost of the test, everything has to be budgeted properly. Then you need to present it to a scientific committee in your hospital. If it's a single center, I insist that the projects are put up to not only the person who's overlooking the study, but to everybody else in the committee. And then it goes to an ethics committee. And unless the ethics committee clears it, you can't start the project. Once you collect the project, the data, you have to look at the hypothesis, you have to look at the statistics, and then once the study is ended, you collect all the information, and then is when you have an outcome in, and then you lock your data, and then you say, this is my outcome of my study. The aim and the end, or the conclusion, has to be the same. I've seen papers where they aim something and a conclusion something else, and that is completely wrong. You won't get the paper into a big journal. And finally, I have to say that before you sit down and write a paper, your research proposal has to be good. Then your paper will obviously be good. And then you put these event rates very, very nicely down and look at it quietly and see where are discuss it out with your colleagues who are part of the study. Absolutely. And then make a paper.
So perfectly put, that how to start and how to put down and improve upon your publication skills, that having the right mindset to start to the end is absolutely important. You should remain focused and obviously take a team along with you. Sir, now from being an academician to being an interventionalist, I have some rapid fire questions for you, sir. You may choose to answer whichever way you like, sir. A drug coated balloon, after spending so much time since last 2 days, you can be biased, or you may not be biased. A drug coated balloon or a drug eluting stent in a STEMI less than 30 years old, sir?
At this point of time, in any subset of patients, we do not have data to say that a drug eluting balloon is better than a drug eluting stent. In fact, otherwise I can give you something. The cage-free trial, which was just published, showed the other way, that the stenting is better. Now the question is, can we do a drug eluting balloon versus a stent? We need a large randomized study before we say one is better than the other. A lot of patients don't need any stent. That's a different story. Plaque erosions don't need stent. Small plaque ruptures don't need stent. Cat death does not even require an angiogram. So many of the MIs don't need some. Now whether those patients who you are leaving alone on medical treatment may require only a drug eluting balloon and leave it alone, I think we need large studies before we convince us.
And I think I expect the same answer, a drug coated stent or a drug coated balloon or a drug eluting stent in an 85-year-old STEMI.
In an 85-year-old STEMI, it may make more sense in my opinion. But again, in 85-year-old STEMIs, we know that primary PCI with stents is good. So I'm not going to deny that to an 85-year-old person. But idea is that if you can get away with a balloon in that scenario, will that be as good? I think again we need some trials in those group of patients, which are very difficult to recruit. An 85-year-old trial, even with chronic stable angina, is difficult. Forget about STEM.
Perfect, perfect, sir. A PCI or a medical therapy in a stable angina, sir?
At this point of time, the data is getting more and more convincing for medical treatment. Remember, the event rates for chronic stable angina at 1 year with good medical therapy is just 3%. So if you have to do any intervention on that patient, that includes not only death and MI, it also includes revascularization. So you have to prove that your intervention is better than that 3%, number one. Number two, medical therapy is getting better and better. You have better antiplatelets, better anti-lipid lowering drugs, better ischemic agents. So it's not what we were talking 10 years ago. I agree, percutaneous interventions is also getting better. But today the pendulum is more towards medical treatment, and those who have intractable angina on medical treatment or a large area of supply or a left main disease or a osteal LAD with left ventricular dysfunction or triple vessel disease is where you look at revascularization first. Whether that is PCI or CABG will depend on many other issues. But I think good medical treatment is the way to go.
And even a more difficult question, PCI or medical therapy in a symptomatic CTO?
So if you looked at the last month's data of CTO, even for LAD, it didn't seem to make any major events difference versus medical management. So again, before we jump into CTO, we need to be clear, is there ischemia territory? Is the patient symptomatic? Because you're doing a difficult treatment. CTO is one of the most difficult therapies, which have the higher complication rates. So dye injection is always higher, radiation to patient and the operator is high. So before we jump into a CTO, I think all these characteristics have to be clear. It's not about the ego of the interventional cardiologist that I can open a vessel. That's not the issue we are trying to prove here. We are trying to prove, is this good for the patient and good for yourself, both. And I think that unless you're damn sure about that, I think we should not jump into a CTO.
Perfectly put, sir. And last, before ending the session, sir, tea or coffee?
I don't mind a coffee.
And again, we are losing badly with the tea here. And thank you so much, Dr. Arijit Mulasari, sir. And we end this session. Thank you so much, sir.
Thank you.
Thank you, sir. Photograph? Okay.